Thank you, Nadine. I can't hear you speak often enough. Your words are a wonderful call to action, as is our next speaker, who doesn't need an introduction because you've already heard wonderful things about Denise Dowd. She'll be speaking next on early childhood education and pediatrics, collaborating to address toxic stress. Welcome, Denise Dowd.
Good morning, everybody. And I drew the short straw because I'm following Nadine. Very difficult act to follow, Nadine. Thank you so much for your remarks. Today I want to talk to you just about a project that's small, a modest project in Kansas City, Missouri. That's in flyover country. I think most of you know where that is. It also has a really good baseball team. Go Royals tonight. My disclosure is this. I also disclose that I am fired up, like Nadine said. In addition to that, I want to say that I hope to also create a little dissonance in the crowd today. That sounds a little controversial, but I think it's with doing disruptive things that we're going to be able to change system to address this. This clearly is a movement that goes far outside of any biomedical framework. So I'm going to tell you a little bit of a story and about this experiment. An experiment is an intentional word. We don't have the answers in Kansas City. We don't have a neat toolbox that we can just give you. But we're trying some things, and some of the things are working, and some of the things aren't working, and we're moving on as quickly, as safely, and as inexpensively as possible because we're frugal there in the middle of the country. And we're doing these experiments to address toxic stress in families at a high risk for poor outcomes. I want to talk to you about the first four things, are sort of conceptual things, and then I'm going to end by talking a little bit about lessons learned. The importance of high parental adversity burden is really, really, really vital to this work in pediatrics. It's just not about the child. The parent's high adversity burden is very important. The importance of, like Nadine mentioned, of a two-generation approach. We cannot disrupt the dyad between the child and the parent. Collaboration between pediatric healthcare and early childhood education, because we have experience with that. Two very important partners. And speaking of partnership, parents as partners, as equal partners in this. But first, before I want to get into the bulk of this, I really need to tell you that I'm not the one really doing the work. The work is being done on the front lines by an assortment of people, and this is some of those people here. And I have immense gratitude to them as their cheerleader. I've been involved with this collaboration really for 20 years when I first got involved with the center that I'm going to talk about. And what impresses me most about this list is that it includes a nurse COO, it includes social work, it includes a senior educator, it includes psychologists, it includes nurse practitioners, it includes physicians, and it even includes 2 nuns, in addition to an amazing group of parents. So this partnership that we're calling the Partnership for Resilience Family has a little bit of a background. We at Children's Mercy Hospital are a very large regional healthcare system that you may have heard of that's in the western side of Kansas City, and we're known for excellence in clinical care. Operation Breakthrough, as it's called, it used to be called St. Vincent's, but the name was changed some years ago so that people wouldn't think it was a Catholic-affiliated organization, is a nationally accredited not-for-profit corporation beginning in the late 1960s by 2 sisters. They were nuns who started it, but they weren't starting a Catholic organization. They broke off from their educational mission in schools to do this when some of the parents brought them babies and said, what about these little ones? The other ones are in school. What do we do about these little babies? And they essentially took them into their house, and this ended up to be Missouri's largest Head Start, early Head Start, and largest federally subsidized daycare, serving about 400 children per day. And kids will go in there as early as 4 weeks of age. And we have a school-age program there as well. And since 1995, so for a number of years, our hospital has had a partnership with that organization in that we have a pediatric healthcare clinic there, a primary care clinic, on site. It's under the same roof. And that healthcare clinic supplied well child health, acute care, immunizations, and provide a lot of the health care requirements that Head Start children need. Well, a little bit of history because I love history and because I think it kind of shines a light on the soul of why places exist. And I think it's the kind of stuff that we should never forget. Children's Mercy Hospital was started in the Progressive Era, 1897, a wonderful time in our history when women were rock stars, real rock stars. And Nadine certainly is channeling the spirit of that Progressive Era. Whenever I hear her remarks, I think of this. But these were two sisters, two biological sisters. One was a surgeon and one was a dentist. And they took children off the street who were homeless, who were quote-unquote crippled, and they took them in and provided medical care. And this then grew into a large children's hospital system, 1897. Operation Breakthrough, also started by two sisters, but they're not biological sisters. They're two nuns, Sister Carita and Sister Berta. And these are amazing ladies. And this was their picture taken a few years ago. They're a little bit older now, a little bit more frail now. And those are some of the children that they take care of in their center. They've also personally adopted, I think it is 6 or 7 children of their own, and they've fostered over 50 children in their own home. So they walk the talk. They're 24/7 doing this mission. Amazing people. And so I mentioned the scope of work of our clinic, the primary school, the primary care clinic, having a school nurse, Head Start compliance, and then, of course, medical and nursing education. So the Head Start program that's there and medical homes, of course, we have common goals. We want to both optimize well-being and potential of children and families, optimize children's readiness to learn and to develop, to address toxic stress, ameliorate and try to help adverse childhood experiences and respond to trauma, and then importantly, to develop resilience. We agree on these common goals. So about 3 years ago, our COO came to myself and of our hospital, came to myself and my colleague Donna O'Malley. And Donna is a nurse, a senior nurse who I worked with long ago in the emergency department. When she was a charge nurse, she went to do child abuse and so forth. And we've been around a long time, and we have a passion for this work and a passion for this operation that is less than 2 miles from our hospital, literally in the shadow of our hospital. And she said to us, "Are we doing our best? Are we bringing everything that we can possibly bring to that organization to serve Kansas City's most vulnerable children? Are we doing our best?" And she, of course, pulled out the financial sheet because we have to talk about that. But she charged us with going over there and finding out what more we could do. Now, mind you, we each had different jobs. We had no authority to do this, except for her informal ask. And we had no money to do this. And we definitely didn't have time to do this. But there we were, asked by the COO to go and snoop around and see what more we could do. So we felt a little unclear, a little perplexed, a little disoriented, and a little bewildered, and I'm sure the people that we spoke to initially felt the same way. What are you doing here, and what do you want? But nonetheless, we pushed forward. And so the first thing we did was pretty simple. Now, as Midwesterners, we just went around and talked to people, sat down and got some cookies and some coffee and just talked to people. We called these key informant interviews, to use a fancy term. We then figured out that we're probably going to need a team of people, both from the medical clinic side and the Head Start side, to sort of form a team that we could seek in terms of advisory, a staff advisory team. Parents were also important, and we were told when we first started the work, they will never show up. They don't make appointments, they don't show up. But we tried, and the first thing we did was, of course, offer a meal. And people do come when you offer food, and when you listen to them, and when you expect them to speak. We did then leadership team powwows that include the COO of our organization, who originally asked us to go over there, as well as the CEO of the organization, Operation Breakthrough. We looked at the clinic staffing, advised some changes, a few changes in personnel, and we established a sick bay. And why we did that, a sick bay, was that one of the things that was said to us by the parents was the clinic doesn't take care of sick children. And we said, well, of course they take care of sick children. It's an acute care place, and you can bring your child there. But what they were really saying is that When you call us up at Church's Fried Chicken and expect us to leave our minimum wage job to pick up our sick child from daycare, we will get fired for that. If there is a clinic there, why couldn't you just watch our child a couple of hours till we get off work so we wouldn't compromise our job, which has no benefits? And this was a big deal for the parents. However, there were many, many, many obstacles to getting that done. People thinking that's not within the scope of practice, we don't have a sick bay, we don't have, stuff that we can do hydration with and so forth. So we had to push through that. Nadine Burke-Harris came to town, the AAP threw in a little bit of money, and we created a little video, which turned out pretty well. We're proud of it. In fact, in the handout that's in the materials, the link is to that video. It's on the Head Start site. And we've used it a lot with funders, so it could be useful for your work too. It's your tax dollars paid for it, I guess, really, so please feel free to use it. We looked at our data review. The intake for Head Start includes lots and lots and lots of different data points because they're federally mandated, and we threw an ACE score, a parent ACE score, and current child adversities into that data. Importantly, and this was the catalyst to the entire thing, is we hired a psychologist. And we got our behavior and developmental pediatrician, section chief, to be on board with this. She had to be supportive of this. And she was supportive of this. And so this psychologist was assigned to Operation Breakthrough. And unfortunately for us, she was the daughter of the man that ran our sickle cell operation for years, decades actually, so there was a nice connection there. And she had a real good basis in community-based pediatric research. And this was like a catalyst for us when she became embedded there. And then, of course, she went on and did a number of observations and shadowing. And I'm going to tell you a little bit about what we found. We found, first of all, that there were a number of challenges, is that it was very clear to us that families there experience very high levels of trauma, current trauma every single day, and toxic stress, in addition to very complex social problems. Homelessness, 25% homeless, or just on the verge of homelessness. And sometimes we think of homelessness as the person with the shopping cart on the sidewalk. Homelessness for these families means couch surfing. It means I get to stay with my sister for 2 days, and I'm going to be with a friend for a day, and so forth. Unemployment, husbands are abusive partners, and so forth. We found also that although the clinic and the Head Start shared the exact same roof and had done so for 15 years, there was not what we would call true collaboration there. There was limited communication because it's natural. They're both kind of tribes that exist and have their own operation, their different financial streams, and so there was really no kind of incentive to work together, other than perhaps you would say the fact that you're serving the same families. Parent engagement was limited, accountability on behalf of the parents was limited, and the need for adult mental health care was immense, really huge. It was a crying need. And again, lack of coordination, fragmentation, inconsistency, always working kind of to put out the next fire. That's how the both operations kind of worked like the families work. What's the next crisis? What's the next crisis? It's hard to make progress when you're only addressing the next crisis. On the other hand, the assets, the positive stuff, was really, really high too. They're seen both as tremendous resources in the community, both jewels in the community, both the Children's Hospital as well as Operation Breakthrough. There were strong bonds and trust between the families and the Operation Breakthrough. In fact, when people spoke, when families speak of Operation Breakthrough, they speak of it like a person. That person is always there for me. And actually, what you see is that now we're on our second and third generation of families coming back to use the facility. So mothers who are having kids see almost Operation Breakthrough and the two sisters that founded it as maternal figures in their life. We saw also the asset of both the staffs recognized the toxic stress was huge and we need to address it. And strong commitment to do whatever it took to make it happen, to support these families. A lot of resilience was another asset. I can't imagine after, I heard so many stories in talking with parents. If that were me in their shoes, I don't know how I would get up to face another day with what their personal stories were growing up, as well as what they had to face every single day, taking 3 buses to drop your kids off at 7 o'clock in the morning, going to a job that paid minimum wage, having to interact with all kinds of social service systems that treated you like less than a person. I can't imagine what that would take. So the fact that these people were standing, caring for their kids, bringing their kids in. It just speaks to their resilience, tremendous resilience. And of course, another asset is the real strong desire to provide quality programs. One of the things we looked at in terms of quantitative data, and I know I'm talking more about qualitative data, but in quantitative terms, we looked at the relationship of the parental ACE score to the current child adversity. So these were parent scores compared to current child adversity, and these were kids before the age of 5. These were all early Head Start kids. And just like anything you see with ACEs, what do you see here? A dose-response relationship. As parental ACE score increased, so did current child adversities. Homelessness in a child, neglect in a child, and separation from parent. And separation from parent is code for Child Protective Services got involved and the child was removed from the home. So you can see that. And again, just like I think it was the educational behavioral problem data that Nadine presented, these are all people with the same demography. These are all people in poverty. These are 85% African American single-headed households, female-headed households, and it's the same thing. So the diversity of ACE score within those populations is tremendous, as is the risk. Again, here's a different set of outcomes with parental ACE score: living with drug abuse, living with domestic partner violence, imminent partner violence, and living in a community with violence. The higher the ACE score in you as a parent, the higher the probability that your child was going to have one of these problems. Very compelling. And so what do we do with all these data, these quantitative and qualitative data? Well, I love Jeff Schoenkauf's quote that says, "Innovation lies at the intersection between early childhood systems and child health." And the child health systems that we were looking at, of course, health, was Head Start, early childhood education, as well as social services, just to name a couple. And really, we had to innovate. And that was the major intervention that we were trying to do, is system change. So one of the things that Donna and I did was we hauled ourselves off to a leadership center that is practicing a leadership education framework that's based on some principles at the Kennedy School. And one of the first things that they kind of teach you in this is that one of the big mistakes people make when they're trying to make change is not distinguishing between technical work and adaptive work. And as a physician, I know, and a ER physician, I know I understand technical work. There's a fracture, we put an IV in, we sedate, we reduce the fracture, technical work. Adaptive work does not have clear solutions. It's extremely messy. The authority figures are not clear. It requires learning, it's iteration, and above all, it requires experiments, and experiments do fail, and that's part of adaptive work. People in positions oftentimes are not real used to failing and being wrong, and that probably was the hardest thing for me to get over personally, and certainly when I deal with my healthcare system, the system in general, this is a hard thing. So adaptive work. We looked at the innovation being integration. Integration for both early childhood education as well as our pediatric health care. We wanted parent and child health care to be considered an education outcome, and we wanted to be kindergarten readiness to be considered a health care outcome, and that the social determinants as the critical foundation for both of those changes. So what we did is we worked with the intake for the Operation Breakthrough staff. This was not the clinic staff, this is us together working. And since they had the closest relationship in terms of providing social services and trust and knowing people over a long course of time, is we worked together to include certain mental health tools within their initial survey in order to establish how parental mental health, what their needs are, and to establish a baseline and what their desired resources are. We needed to understand the burden of parental depression, trauma in terms of PTSD symptoms, ACE scores, and as well as their emotional regulatory ability for those parents. And then also help parents identify support modalities. We wanted to know what they wanted, not what we thought that they should have. These are the measures that we use. We use the patient health questionnaire 9, that is the depression inventory, PHQ-9. It works very well in primary care, and it works very well for our population. It's self-report, 9 questions, easy to do. We use the 4 screening primary care post-traumatic stress screen. We use the DERS scale, subscale, to look at emotional regulation. We use the traditional Onda and Folletti ACE score, not Nadine's score, but we'll probably do the expanded one next year. And then services desired. Here's our results, just really quickly. Initially, 142 parents completed the survey. Their mean age was about 30. 36% had 2, more than half had 2 or more children in the program. And some of the stuff we found, it was actually pretty shocking to us. The amount of untreated mental and behavioral illness there among the parents was enormous. More than about 1 in 5 of the parents was at risk for a major depressive disorder, and that's well above the national rate of about 7%. Again, untreated. PTSD, 22% screened positive for PTSD. Now, of course, this is not a full-blown diagnosis. This is just the screening. That's much higher than the national prevalence for about 8% of all U.S. adults screening positive. ACE score, 35% of our parents had an ACE score of 4 or more, and you heard what Nadine said about the risk for ACE score of 4 or more. And these are parents that we're seeing in the medical clinic trying to do anticipatory guidance about how they should parent, and about seat belts, and about car seats, and about poison control and smoke detectors. Now, talking to people who have such degrees of emotional, of dysregulation, high ACE scores, who are also in critical state of losing their houses, being homeless, is a very difficult thing to do. And so our primary care had to be informed of that. Services desired were really interested, and this was kind of a fill-in-the-blank thing. This is not a checklist that we came up with. Parents really desired family nights, opportunities to be with their family. They wanted meditation and yoga. That was a shocker. Who would think girls in the hood want meditation and yoga? That was a shocker to us. They wanted to have opportunities to exercise. They wanted adult health services. They wanted parent-child relationship support, cooking classes, and also parenting classes. They wanted help with parenting. So how do we then build this partnership to address toxic stress? What is it that we're doing? And I'll say that we're doing, not that we did. We've done some things, but we have so far to go. So the idea then is to take all of these players, not just healthcare, but early childhood educators, psychologists, yes, pediatrics, social work, and parents. And I think of these as different tribes. I think of these different boxes here as having their own culture, their own language, their own financial drivers, their own reward system. And to do collaboration is an easy thing to say, but when you have different cultures and different ways of doing things, even within healthcare, psychologists have a different framework than social workers do. In fact, one of the things I do when I engage social work and psychologists, when I talk about this stuff, is I apologize and say, you know what, yeah, I'm a pediatrician and I'm talking about this. And how long have you been talking about this? You've been talking about this for decades. And I say, yes, the biomedical model is a little late to the game, but you need us because we will help magnify your effect. But yes, you are right, and you've always been right. In fact, I was just finished reading a book about Jane Addams, and it's called Spirit in Action, which is a fantastic book about Jane Addams' work. And I can hear her ghost calling from Hull House on Halsted Street in Chicago saying, I told you so. But it's true, and I think we have to tell our colleagues in other disciplines, we have to give them credit for this. We can't approach this as just, hey, guess what we just discovered? It is just not right to do that, and it is foolish to do that as well. These are very important players for us. So our psychologist has this wonderful CBPR background, Brianna Woods-Yeager, and just a brief little sort of a review about how traditional research differs from community-based participatory research. Traditional research is the academic research is the expert. We are the expert, you are the subjects. Yes, you might advise us, but we are the expert. CBPR does not think that. All partners have expertise coming from their own framework. We are all on equal footing. In traditional research, the goal is to prove a hypothesis and to publish a paper and to hopefully get NIH funded and to get promoted. CBPR, really the primary goal is social action. Yes, we want generalizable knowledge. Yes, we want to publish papers, but this goal, the primary goal is change. It's social action. And unfortunately, in traditional research, much of the time, the researcher is separated physically and emotionally, importantly, from the community. But in CBPR, the academic researcher and the community partners together and work together. In fact, our psychologist is there in the building with that program. As part of this, we developed a community action board, and the community action board is composed of all the different entities I named, especially parents. And the goal initially has been to develop and disseminate toxic stress prevention resources that are relevant, and I'll underscore relevant, and accessible to our families. And I mentioned those are the players there on the bottom that compose the community action board. So here's some of the action, or some of the input that the parents have put in. And we basically shared the science of toxic stress with them, literally with them, whatever they wanted, and talked to them about it. Put it on the table. Any materials from the AAP, anything that came along, we put it out on the table and said, what do you think of this? Talk to us about it. And I'll tell you, it was eye-opening. Parents already know this stuff. It's just not been given a name other than, what's wrong with you? You're a bad parent. Why can't you control yourself? Why don't you just settle down? That's the name this has been given to them. We give it a different name. We gave it this name, toxic stress. And so they thought it was really important for us to educate on the connection between physical and mental health, important that it be credible to the population we serve, that it promote, number one, loving interaction between parents as children. Don't lead with pathology, lead with love, lead with relationship. And emphasize this notion of thriving. We put the term resilience on the table. They were like, we don't know what that means. That has no meaning for us, but we love the word thrive. And it definitely supported these parents as protective and loving figures for their children. That's our Community Action Board. It's a beautiful diversity of cultures there, and I'm not talking about ethnicity, I'm talking about the walks of life. Parents, psychologist, nurse, physician, and so forth, social work. There's one father in there. Our gender diversity is not so good, but we're working on it. We're working on it. We do have one father, Carlos. He's in the back. He's trying to get attention there. To date, there's been a lot that's been done. Donna O'Malley, my colleague, is here somewhere there. She's presenting a poster and has some of this stuff, including materials to share with you on how toxic stress has been defined. Looking at a common language. We've talked together about community-based participatory research, starting very gently, bringing parents as partners. And this is hard to do. Try to get, a parent that needs to get human subjects education and as a co-investigator and try to convince an IRB that this is the thing to do. It's really hard to do. It's hard, and it's unusual, but we have to do it. And any materials that come in to build this program to address toxic stress have to be vetted through the parent group. It's mandatory. It's not going to happen otherwise. So the first thing was parent definition, and the parents have come up with their definition of toxic stress. What does toxic stress mean to you? So here's the definition that was a consensus definition from multiple parents, and this is what it is. Toxic stress is stress that is damaging to our physical, emotional, and mental health. Toxic stress seeps under the skin and into our bodies, causing pain, and it's contagious and unhealthy for our kids and families. That's a great definition. You can feel toxic stress. And then they came up with the proposed solution there, including a comprehensive programs of supports, with an emphasis on breaking the recognized intergenerational transmission of toxic stress, an emphasis on we don't want to hand out, we want to hand up. And unfortunately, well-meaning social service agencies, including philanthropy and charity, have oftentimes given hand out and not much of a hand up. And I think it's really important to distinguish that. We want validation about toxic stress. Just naming it is a big deal. So like Nadine said, do you have to have an intervention? Do you have to have the perfect screening tool? Naming something is the first step to managing it, and is the first step in trauma-informed care, and it's very, very powerful. This is a handout that the parents came up with on what toxic stress is. I thought the idea of creating a non-word verbal or a graphic on what toxic stress is, because some people are completely illiterate, functionally illiterate, was really, really smart. And this is brought to you by our parents, and we can freely share that with you, no problem at all. But I think this is really fantastic. The middle line is really important, and that says, the bottom line is that toxic stress can travel from one generation to the next, but it does not have to. Kira is one of our parents. She wanted to. We met last week in our Community Action Board, and she said, I have an idea. Could I just provide you with a quote? I didn't ask for this. She said, could you tell your group why this is important to me? And she said, giving toxic stress a definition helped me to identify it within myself. I'm now able to recognize a trigger or flare-up and catch myself, especially when interacting with my children. I stop and think and try to curve my immediate reaction into something better. Beautiful. So we're calling this integrated behavior and mental health the 2-Gen Thrive model. This was the name that was settled on by our parents. And 2 simple things is to diminish significant adversity and increase loving, supportive, stimulating experiences and relationship. It takes relationships, and I quote Andy Garner, who says, it's about the relationship, stupid. Not just the parent and child, but between the teacher and child, and system relationships between education and healthcare. And that's where our innovation is coming forward, with mutually shared goals about attachment, school readiness, health, well-being, and resilience. So we're continuing to build that partnership. I'm going to skip over this real quick. I'm going to talk to you about one of the things that we're doing there, and then I'm going to show you a matrix about how we fit this all together. This is a simple thing called the Parent Cafe, and some of you may have heard of the Parent Cafe, but the Be Strong Families organization, which started in Illinois with Strengthening Families operation, came up with this. And it's based on the World Cafe model about how you get groups together to build consensus. It's informal, you meet, you have food, and you talk about different things of importance to the group based on a structure of questions that actually come kind of prepackaged, based on the 5 protective factors, which is social connection, parental resistance, knowledge of parent and child development, connected support in times of need, and social emotional competence of children. And it's a really wonderful way to build empathy and peer support. And this is some of the things that they've talked about, how to find strength through being a parent, the difficulty in differentiating your own needs from your child's needs. They're so intertwined, and that's why this 2-generation model is so important. The uniqueness of kids, and much concern about racial injustice and segregated communities and disparities that has to come out on the table and be discussed. It's a wonderful, wonderful group. And you can get it, comes in a box, Parent Cafe in a box, look it up, buy it, it's $25. You can do it. It's not magic. This is the plan overall. We're not going to parse all of this out, but we do universal prevention, targeted prevention for those at risk, and then intensive intervention. Just picking out a couple of the intensive things: evidence-based trauma treatment. We have a trauma treatment center which does trauma-focused CBT and CBT and trauma-focused CBT, dialectical behavioral therapy. The targeted prevention, you can see there is this early childhood mental health consultation, which means we have a psychologist in the building, is what it means. And when we look at this matrix, we look at it in terms of the child, their main adult in their life, as well as staff intervention. We have found that the staff that serve kids in these communities themselves are from the communities, themselves have high burden of adversity in their lives, and they absolutely need help as well. So there's a lot of mindfulness-based stress reduction stuff going on, and wonderful staff development that wasn't going on before. But you need to address all of that stuff. How do we measure our success? We have to have shared measurements, and this is really hard because we have HIPAA on one side, we have FAAP on another side, but we got to figure out a way to share these measurements, and we are working on it. Mutually reinforcing activities, different but still highly, highly coordinated. We must plan together, and not just cooperate, but plan together. constant communication, and we have to have a backbone organization for the entire thing. What did we learn? And then I'm going to end. Well, it's really important to recognize the indigenous wisdom of the people that you're serving. There is a tremendous amount of wisdom there. And we take the approach of cultural humility as opposed to cultural competence. I can never become competent in somebody else's culture. I have my own culture. I'm not going to be competent. So we talk about cultural humility. Collaboration makes sense and benefits all involved, but system characteristics create significant barriers. And I use the term tribes. Like I said before, it's very difficult to get systems to interact, but it can be done. And in order to move on toxic stress, we have to knock down those barriers. They don't change quickly. Expect to fall down but you got to get back up again and again and again. And you have to communicate all the time. Tiny little baby steps need to be celebrated over and over again. It's an iterative approach. And we have to convince our funders that that's what it is, an iterative approach. So we won't fail. But together we can accomplish so much, and it's worth it. For any further information, contact our people here. I'm happy to give you those if you don't have time to write them down in this moment. So wonderful people, and thank you for your attention.